Did you know that 70 to 80% of men develop erectile dysfunction after radical prostatectomy, and only 5% of men with ED after prostate cancer surgery end up getting surgery for penile prosthesis? If you or someone you love is facing erectile dysfunction after prostate cancer treatment, you deserve to know what's possible. Hello, my name is Dr. Jonathan Clavell, and I'm a board-certified urologist and penile implant expert in Houston, Texas. For so many men, beating prostate cancer feels like the end of the battle. But for a lot of guys, it's the start of a new struggle. They beat the cancer, but now they struggle to regain their confidence, intimacy, and ability to be able to have sex the way they want to. The reality is, prostate cancer treatments, whether surgery or radiation, often damage the nerves and blood flow needed for strong erections. And while medications or devices can help, they don't work for everyone. That's why today I will break down everything you need to know about penile implants after prostate cancer treatment and why penile implant can be life-changing for men who undergo radical prostatectomy for the treatment of prostate cancer. Yet, so few ever hear about it as an option. In today's video, I'll cover why ED happens after prostate surgery and radiation, what penile rehabilitation is and why it matters, when is the best time to consider an implant and what happens if you wait, and how urinary continence, orgasm, and climacturia affect your decision, and finally, the key surgical details like anatomical changes, reservoir placement, and realistic expectations for outcomes and satisfaction. First, let's address why we're even having this conversation. Prostate cancer treatments, whether surgical or radiation-based, frequently lead to erectile dysfunction or ED. How is that? Let's start with a quick anatomy lesson. Look at this picture. This is a front view of the man's pelvis. You can see the bladder right in the middle, the prostate below it, and then the penis with the urethra that connects with the prostate. The nerves that gives us erections are called the cavernous nerves, highlighted in the picture in color yellow. This originates from the spinal cord and from a cluster of nerves which we call a plexus. And these surround the prostate like a spider web from the side and below that prostate. Now look at this picture from the side, called a lateral view of the male human body. Again, here we are looking at the body from the side, and you can identify the cream-colored structures in the middle, which are the bladder on the top and the prostate right below it, and you can also see the yellow structured nerves that go at the side and below the prostate and then the penis. A very important thing to also note on this side view is that these nerves are also surrounding the colon, which you can see on the top right of the picture. Therefore, men who undergo surgery for rectal cancer, which is a form of colon cancer, can also have nerve injury to the cavernous nerves and end up with erectile dysfunction. Now back to prostate cancer. When the surgeon removes the prostate, the nerves that gives us erections, called the cavernous nerves, can get damaged, stretched, cauterized, or sometimes even cut during the surgery. These are not the sensation nerves, but rather the erection nerves. These cavernous nerves are responsible for sending the signals that tell the penis to fill with blood and give a man an erection. Even those men who have nerve-sparing surgery are at risk. Why? Imagine that the cavernous nerves are my fingers and this ball right here is the prostate. The nerves lie below and lateral to the prostate. And when a surgeon is dissecting those nerves for nerve-sparing surgery, he has to separate the nerves away, and that stretching of those nerves during dissection can lead to injury that, as with any other injury, would need time to recover. Moreover, during prostate surgery, there is risk that the blood vessels around the area can also be affected, reducing healthy blood flow to the penis. Without the nerve signals and regular blood flow to the penis, the erectile tissue can get weaker, and without blood, there is lack of oxygen, and therefore scar or fibrosis can start to form, making it harder to have erections even if the nerves underwent nerve-sparing surgery. In short, it's not that the penis is removed or broken, but the pathways that trigger erections can be injured. That's why some men have trouble getting or keeping an erection after this surgery. You might wonder, but how common is ED after prostate cancer treatments? Well, research shows that erectile dysfunction develops in approximately 70 to 80% of men after radical prostatectomy for prostate cancer. Again, at least 7 out of 10 guys can develop ED after prostate cancer surgery. Medical research indicates that less than 20% of men report erections firm enough for intercourse at 6 months to 3 years post-surgery, and this rate declines to 17% at 6 years. And while nerve-sparing techniques can improve outcomes, they do not eliminate the risk entirely. And as you can imagine, if the cavernous nerves are not spared during surgery, we expect those men to have even a lower rate of recovery. Again, this is 4 out of 5 guys undergoing prostate surgery report having erectile dysfunction. How about radiation therapy? If you got radiation therapy for prostate cancer, the percentage of men who develop ED is approximately 34% at 1 year, and this increases to about 60% at 5 years. These rates are according to pooled estimates from systematic reviews. What this means is that sometimes the onset of ED after radiation therapy is often delayed compared to surgery, which causes a gradual decline over several years. And one important factor that we need to consider is that radiation therapy is often accompanied by a therapy called androgen deprivation therapy, which are medications that suppress testosterone in the body, and this itself will also lead to further low libido, erectile dysfunction, and tissue atrophy. Now, one of the most common questions that I get from men diagnosed with prostate cancer is, well, doc, will my erections come back after prostate cancer surgery? The truth is, there are a few key factors that may predict how well a man can recover his erectile function. Those factors include, number one, younger age. That is, men younger than 55 years old undergoing prostatectomy have a better chance of recovery. Number two, men who have good erections before surgery. This makes sense. If you are younger and have good erections prior to surgery, you have a better chance of recovering your erections after surgery. Number three, those who have a bilateral nerve-sparing procedure. Depending on the severity of your cancer, some surgeons might try to preserve the cavernous nerves, and if those are preserved, you have a fighting chance on getting your erections back. Number four, those who are healthier. That is, no major vascular issues like heart disease, diabetes, smoking, high blood pressure. And number five, those who commit to penile rehabilitation after surgery. Now remember, every patient is unique, but these 5 factors give you the best odds for regaining strong erections after prostate surgery. We mentioned penile rehabilitation. Penile rehabilitation in the context of erectile function recovery after radical prostatectomy refers to the use of pharmacologic and/or mechanical interventions initiated soon after surgery with the goal of preserving or restoring erectile function. In layman's terms, penile rehabilitation means helping your penis recover its natural function after prostate surgery, pelvic surgery, or other treatments like radiation therapy. Think of it like physical therapy for your penis. Just like you might do exercises or use equipment to get your knee or shoulder working again after an orthopedic surgery, penile rehabilitation uses different methods to exercise the erectile tissue so they stay healthy and don't get weaker from lack of use. So, what do we use for a penile rehabilitation? Urologists typically recommend early initiation of a combination of the following. Number one, medications like sildenafil or Viagra or tadalafil/Cialis to help bring blood flow. Also, a vacuum erection device to mechanically stretch the penis. Some sometimes consider the intracavernosal injections like Trimix, and in some occasions, pelvic floor muscle therapy. Early and intensive rehabilitation can certainly improve the likelihood of erectile function recovery, but a substantial proportion of men still remain without response to these conservative approaches. In brief, penile rehabilitation means starting treatments early, like low-dose tadalafil or Cialis, using a vacuum pump or sometimes even injections to help keep blood flowing to the penis while we wait for your cavernous nerves to wake up and start working again. Why does this matter? Because keeping the tissue healthy helps prevent scar tissue from forming and gives your body the best chance to recover natural erections over time. So remember, penile rehab isn't about instant results, it's about protecting your future function and maximizing recovery. Talk to your doctor about what rehab plan will be right for you. Let's say you are doing penile rehabilitation for a while but haven't seen the results you were expecting after prostate surgery. When do we consider a penile implant? This one is a tough question because there is no universal answer for this one. This truly depends and might be different for every individual. Most experts recommend waiting somewhere between 18 to 24 months, especially for those who underwent nerve-sparing surgery. But in reality, it depends on the individual. If you had great erections prior to your surgery and had nerve-sparing surgery, it is reasonable to wait. However, if that man had so-so erections or was already struggling prior to his prostatectomy, many experts would consider it very reasonable not to wait too long for that implant. Research studies mention that approximately 20% of men, that is 1 out of 5 guys, recover their erections by 2 years. Therefore, by 2 years, 80% of men are still unable to get strong enough erections for intercourse. 2 years is a long time. Therefore, I have a different philosophy. Once you've given yourself the best shot with penile rehabilitation, regained your urinary continence, and at least 6 months have passed from your surgery, if you're still not seeing results and it's affecting your quality of life, it is reasonable to start thinking about an implant. or it's been a few months, you are not satisfied with the quality of your erection, and you have a penile duplex ultrasound that has confirmed the venous leak, which research has shown that those patients do not get much better with time, then I believe it's absolutely reasonable to start considering for penile implant surgery. In my opinion, there's no sense in waiting 2 years if you're frustrated and your erections aren't functional enough for penetration. Remember, about 80% of men still won't have satisfactory erections by the 2-year mark. So 2 years is a long time to feel stuck. So if you're dry, not leaking urine, and you've done the work with rehab but progress is slow, you don't have to put your life on hold. A penile implant can restore spontaneity, confidence, and intimacy, and that can be life-changing for you. Remember that 70 to 80% of men develop erectile dysfunction after radical prostatectomy, and even more shocking is that the percentage of men with post-prostatectomy erectile dysfunction who ultimately undergo penile prosthesis surgery is less than 5%. Specifically, there was a large statewide claims database study found that among almost 30,000 men who underwent radical prostatectomy surgery for prostate cancer, only close to 1,500, which is less than 5%, subsequently received the penile prosthesis with a mean time to implantation of 2.6 years after surgery. What this means is that 1 out of 20 guys, again, only 1 out of 20 with ED after prostate surgery ended up seeking a solution for their ED, and they waited an average of 2.5 years. As an expert in sexual dysfunction and penile implant surgery, I find these statistics to both be bizarre and a little worrisome. Why? A man who is battling to get regular erections for 2.5 years is a man that can end up with atrophy, penile shortening, and therefore less satisfaction than if they had their surgery early on. So remember, penile implant surgery is not the last resort for the treatment of erectile dysfunction. When planning penile implant surgery, it's also important to understand the specific factors that can affect men who have undergone prostate cancer treatment. Number 1, timing between surgeries, that is, from your prostatectomy to your penile implant surgery. After the prostate gets removed, every single guy has erectile dysfunction initially. Some men recover their erections early on, but others do not. Therefore, those who are not getting regular erections or are not in a robust penile rehabilitation program will undoubtedly form fibrosis or scar tissue either inside the cavernous tissue or the tunica albuginea, which will lead to shortening. Men who have their prostates removed and have either their nerves injured or dormant undergo a process called hypoxia, which is the term for lack of oxygen. And without oxygen, the tissues start to shrink. So yes, men who undergo radical prostatectomy are at risk for what we call hypoxia-induced fibrosis, scar tissue within the corporal bodies, and in some occasions, there could also be scar tissue in the tunica albuginea, which will lead to Peyronie's disease. And to give you an idea, close to 15% of men undergoing radical prostatectomy develop Peyronie's disease, which is higher than the general population. The second factor to think about when considering a penile implant after prostate surgery is your urinary control, or what we call continence. After radical prostatectomy, many men have urinary leakage at first. For some, it can take several months to regain full control. Others may need more time or even additional treatments to help them stay dry. Why does this matter for your penile implant? It is simple. You really want to have your urinary leakage well controlled before getting an implant, because the chance of that improving after implant surgery might be less. Most experts recommend waiting until you have good urinary control, or at least have tried all the options to manage leakage before moving forward with an implant. In general, we want you to feel confident with urinary control so that you're not constantly worried about pads or accidents before focusing on restoring your erections with surgery. If you're not fully dry yet, don't get discouraged. Talk to your surgeon. There are additional procedures like a sling or an artificial urinary sphincter that can help you regain continence and prepare you for the best possible implant outcome. The third factor to consider when getting a penile implant after radical prostatectomy is if radiation therapy or hormone therapy are given or to be expected to be given. Men with higher risk prostate cancer or positive margins sometimes require both prostatectomy and radiation therapy, with the addition of androgen deprivation therapy, which are medications that suppress your testosterone levels. Depriving a man from testosterone can lead to tissue atrophy and low sex drive. For those who have had radiation therapy, sources indicate that it can cause further scarring of the penis. This will not preclude you from having a successful surgery, but it's another factor that can affect the size of your implant, especially if you wait a long time to get one. The fourth factor to consider when getting a penile implant after radical prostatectomy is reservoir placement. There are several areas in your abdomen and pelvic area where, as surgeons, we can place your reservoir. We can place it in what we call the paravesical space in your pelvis or space near the bladder, and we can also place it underneath your abdominal muscles. When a prostate gets removed, the anatomy of your pelvis changes. Organs and other structures in the pelvis may have shifted around during that prostate surgery. Therefore, it is very important that as surgeons, we take good care at trying to avoid injuring those organs when placing the reservoir. If you are in the hands of an experienced surgeon, we are certain that we will take good care of you and make sure that the reservoir is placed without injury. The fifth factor to take into account for radical prostatectomy is orgasm, because sexual function is more than just erections. After a radical prostatectomy, your prostate and seminal vesicles are removed. The seminal vesicles are the glands that produce most of your semen. That means that you'll still have an orgasm, but it will be what we call a dry orgasm, meaning there's no ejaculation of fluid. This is completely normal and not harmful, but some men feel surprised or sometimes even disappointed if they're not expecting it. So it is important to know that dry orgasms are a normal part of life after prostate cancer surgery. This is something that every man experiences after radical prostatectomy. Orgasm can sometimes change and become painful, which is rare, and in some occasions, some men sometimes state that their orgasms are more intense after prostate surgery than before surgery. These last two changes in orgasmic sensation are believed to be related to changes in the pelvic muscles after prostate surgery. However, another common issue that can come up and is rarely talked about is leakage of urine during arousal or during climax, called arousal incontinence and climacturia, which means urine leakage during orgasm. About 30% of men, that is 3 out of 10 guys, experience this at some point after prostatectomy. It happens because the sphincter muscles that control urine flow can be weaker or because of changes in how the pelvic floor works. For some men, it can feel embarrassing. Others do not mind as much. The great news is that there is a specialized technique often performed at the same time as an implant called the Mini-Jupette Sling. This graft or sling is placed at the time of penile implant surgery and provides additional support to the bulbar urethra. This involves placement of a small synthetic or biological material that is sutured to the corporal bodies to create a hammock effect that compresses that urethra when the implant cylinders are inflated, thereby reducing or eliminating urine leakage during orgasm without causing obstruction during voiding. Again, this sling goes from one corpora to the other, with the urethra being in the middle, and when the man inflates those cylinders, the sling will slowly start placing tension and will compress that urethra, which will prevent the urine from leaking out at the time of orgasm. Clinical studies show that the Mini-Jupette graft leads to subjective improvement or resolution of climacturia in the majority of appropriately selected patients. This procedure is particularly suited for men with climacturia and the mild stress urinary incontinence, that is, those requiring 1 to 2 passes per day and who are also candidates for a penile prosthesis. One of the most important parts of this journey is having the right expectations before you go into surgery. You need to know what the surgery involves, what the risks and benefits are, what changes you might see in your penis, like some possible shortening if you wait too long or changes in sensation, and how the device works mechanically, because no implant is exactly like your natural erections. But with a good surgeon that has your best interest in mind, provides good support and education on how to use it, most men and their partners are very satisfied. So if you're thinking about an implant, take time to talk openly with your surgeon, get your questions answered, and make sure you have the right support before and after surgery. That's how you set yourself up for a successful surgery. In summary, erectile dysfunction is extremely common after prostate cancer treatments, but very few men ever hear about penile implants as a real solution. Understanding why ED happens, how penile rehabilitation works, and when it's reasonable to move forward with an implant can help you avoid unnecessary delays and frustrations. Remember, the timing, your urinary control, prior treatments, and realistic expectations all play a role in achieving the best possible outcome. If you've done the work and you're still not where you want to be, don't lose hope. A penile implant can restore your confidence, intimacy, and quality of life. If you're looking for an expert, we are here to help you regain control and satisfaction in your sexual health. Remember to like and subscribe if you haven't, and check out our other videos for more information. I wish you the best of luck in your journey.